Good afternoon, and welcome to this CAQH webinar, a 360-degree view of Cigna Healthspring strategies for improving provider directories. My name is Karen Waller. I'm the Marketing and Communications Director for CAQH, and I'll be the moderator for today's webinar. Before we get started, I would like to review some housekeeping details for everyone listening today. Today's session is being recorded, and by the end of the day tomorrow, you should receive a link by email to the on-demand webinar that you can share with others or review yourself. Both the recorded webinar and the slide presentation will be posted on the caqh.org website. Your phones will be muted throughout the webinar today, so please direct all questions to be submitted online. You can ask your question at any time during the presentation. Simply type your question into the right-hand side of the GoToWebinar post box. We will address your questions at the end of today's presentation. I'd like to introduce our speakers for the webinar today. First is Krista Lehm. She is the Director of Delivery System Support at Cigna Healthspring. And also Ron Urwongse. He is a Senior Product Manager at CAQH. I'm now turning it over to Ron.
Thanks, Karen. Thanks, Karen, for the introduction. So as Karen mentioned, we're going to be focusing today on practical real-world approaches for improving directory accuracy for health plans. I'm going to start with a quick recap of the state of the industry. We're about 22 months in from when some of the CMS regs first came online. See what the regulators are doing with regard to monitoring what the health plans have tried to date. Some of your survey responses will be presented as part of that, and how all of it has worked, how effective it is. We'll also do a quick run-through of CAQH's solution, Directories, including some new exciting improvements that make provider responses much more actionable for health plans. Then we'll hand it off to Krista. She's the directory lead at Cigna Healthspring, and she's been managing provider data strategies for multiple health plans for 10 years, so she's got a ton of real-world experience. I'm delighted to present to you. I certainly learned a lot from her, and I'm hoping that you're going to see some of the same benefits from hearing her stories as well.
CAQH streamlines the business processes in healthcare to reduce the administrative burden on health plans, providers, and patients. We are a nonprofit alliance of 12 health plans and 2 related associations. Their input helps guide the development of our collaborative initiatives. Our work is divided into 3 types of effort. CAQH Core develops operating rules that enable the electronic business transactions between payers, providers, and vendors. CAQH Solutions are technology-based, industry-wide utilities that address some of the most pressing challenges in healthcare related to provider and member data. And finally, Explorations encompasses our research efforts, such as the annual CAQH Index, which measures industry adoption of electronic business transactions. As I said, many of our solutions address the industry challenges of provider data. We'll go through these real quickly. CAQH ProView is used by more than 1.4 million healthcare providers to maintain and share their professional and practice information with over 900 participating organizations. Next, we've got Directories. Directories improves the accuracy of provider directories. It integrates with CAQH ProView, making it easy for providers to update their practice data all in one place for multiple health plans. Moving on, Verified has transformed primary source verification for credentialing, automating it so that it's faster with higher data quality at a much lower cost. Furthermore, Sanctions Track provides ongoing monitoring of provider disciplinary actions. And then we've got Enroll Hub. Enroll Hub increases providers' participation in EFT and ERA, enabling them to use one online application for multiple plans. And then finally, we've got COB Smart. COB Smart addresses the industry challenges of members with overlapping benefits so that claims are paid right the first time around.
Okay, so let's jump right into Directory. So it's always good to take it back to the patient. Of course, we want to help health plans become as compliant as possible with the regs and reduce compliance risk and reduce risk of fines, of course, and streamline that process. But the reason we're in the situation we're in right now is because patients have historically had a very difficult time finding the care they needed. And that's definitely been exacerbated by some of the the influx of new patients into the system due to the Affordable Care Act and Medicaid expansion. But I mean, that's the reason we're getting the regulatory requirements we are from CMS and the state governments. So what you see here, this is a little bit of a stylized example of how a patient can get into trouble with provider directories. And I have to say, for myself personally, I've experienced almost every single one of these things in the past year as I'm finding care for myself or for my kids. So let's say, at the very left-hand side, during open enrollment, you've got, as a beneficiary, you've got multiple options, HMO this, PPO that. What are you interested in? So how do you make a decision on what plan you enroll in? Among other factors, including what the premium is and all that. You're going to be interested to see if your doctor, your kid's doctor, is in network for that plan, right? So you'll take Dr. Smith's name, punch it into the health plans directory, see if they're network, and lo and behold, Dr. Smith is a network. That's good news. Now, let's say 3 months later, you've got to make an appointment with Dr. Smith, and for a particular condition, you call up the doctor's office to try to make an appointment. So a couple things can happen here that'll get you in trouble. So first of all, maybe the phone number doesn't even work. That's kind of a deal breaker right there. Or the provider's not practicing at the location. Maybe the provider is at a location within the group, but it's way across town, not at the location that you were hoping that they were in. Or the provider is just completely out of network or no longer accepting new patients. So you've got a couple of choices here. You can proceed with getting care for this provider, even if he or she is out of network, and pay these out of network bills, or you have to go back to the drawing board and find a new doctor who's going to be able to meet your needs. And it's likely that you won't be able to get an appointment for some time. So as you can tell from a patient perspective, this is incredibly frustrating. I know that most of you have had to deal with these types of experiences as patients or beneficiaries in the past year or even beyond that. So let's move to the next scenarios here. So we talked about the patient pains. Now we'll talk a little bit about the provider and the health plan pains. So this is really around the exchange of this directory information from the providers and plans, and there's plenty of pain to go around here. So on the left-hand side, providers are just receiving an overwhelming number of inquiries and confirmation requests from multiple plans. Being asked to update this information via fax and provider's portal, postcards and group files. So there's not a standardized way for these questions to be answered. Sometimes there's not even a standardized list of questions that the plans are delivering. It's perhaps different questions on a per plan basis. And then on the right-hand side, the health plan challenges. So, and you guys are incredibly familiar with these. You might not even have the right contact information for the provider. So even if you wanted to validate the information, you can't get in touch with the provider or their location. Or if you have the right contact information, it might be unresponsive, and that's understandable. They're getting all of these inquiries and all of these requests from plans and their vendors and call centers. So they may just be unable to answer these requests. And even if they provide the responses, perhaps it's incomplete and perhaps it's inaccurate. So all of these combined together help explain where we are right now. And where we are is that we've got some of these regulatory requirements. So let's go to the next slide so most of you are familiar with the federal regs. And what we've displayed here are specifically the Medicare Advantage ones, but there are Medicaid and CHIP requirements and the federal marketplace requirements as well. But I'll highlight a few of these. So the quarterly outreach, that's an undue burden upon plans and providers. Of course, obtaining accurate information, and we know that CMS has hired some contractors to make sure that this information is accurate, and then the 30-day timelines for updates. But there's also been a proliferation of state requirements as well, and Krista's probably going to talk about a few of these that have been affecting Cigna Healthspring. California SB 137, that's the one that everybody talks about. So this is plans requiring an affirmative response from providers. Most of the regs don't go that far. Most of the regs say you need to provide outreach, you need to get accurate information, but California goes ahead and says you need the provider to provide an explicit affirmative response that the information is correct. Georgia, they're taking a play out of the NCQA and NAIC playbook on doing statistically significant sample sizes of accuracy. Illinois is shifting some of the cost burden from the patients to the managed care organizations. And in Texas, of course, they've been increasing the frequency for updates from 30 days, as we've seen from most of these other regs, to twice a month. So proliferation of regs, requirements, and causing even more burden upon plans. So going into some more detail about what's happening at the federal level. So CMS is taking a bit of a three-pronged approach for directory improvement. Of course, I mentioned before, they've hired a contractor to monitor health plan directories. So they're actually calling up, simulating the patient experience, seeking care, and they're assessing, whether a provider's at a location, if the phone number is correct, if the address is correct, if the provider is in fact accepting new patients. So comparing what reality is from the patient simulation perspective with what the health plan's directory says. They've released some results earlier this year. These are from the January report. We're hoping to see some updated results soon so that we can see how we've been progressing as an industry. But, most of you have seen some of these results before, but, about half of overall location records are inaccurate. Almost half of providers have at least one deficiency. And then I think the key strategic point here is that of the deficiencies, a majority of them, so 66%, are where the provider's not practicing at location. So there's some strategic focus here. And if we could go to the next slide, this is a drill down of that dimension here, where you got about half of locations within a health plan's directory being inaccurate, and then of those, 66% of them, so a majority, are where the provider's not practicing at the location. And then the rest is kind of shared across these different error types, so phone numbers or addresses or accepting new patients. So there's really strategic opportunity for health plans and those helping health plans to focus on this one type of error and ways we can scale up the approach here. Okay. So here's some new information, which I think you're going to be pretty interested in, just to see where your peers are in terms of progress on the directory front. So some general information, we'll get into some specifics. So at CAQH, we had a hypothesis that most health plans have been audited at some point within 2016 or 2017, and that these audits have been motivating plans to do their own internal audits on an ongoing basis to make sure that if they're employing any strategic initiatives to improve data accuracy, that those are improving. We also know that there have been some industry association pilots with other vendors to see if there were scalable ways, via outreach or analytics to improve directory accuracy. And those reports have shown mixed results. So both on the response rate side, which they've had some results there, been able to get providers to respond a little bit, but also on the accuracy improvement side. And what we've seen is it's not some of these association pilots haven't been complete solutions. We've also heard that from many health plans, because it's often perceived as the easiest approach to get started with, that they're just calling these providers at their locations. That's kind of what CMS is doing. So let's do the same thing. Let's hire more people at our call center and call up every location that we can in our directory, see if the phone number works, see if the provider's practicing at the location. And when you can get in touch with a provider or get in touch with somebody who knows the right information, phone number. That results seem okay, seem pretty good, but I think the key here is what kind of response rate do you get via this method? So we want to test our intuition here, and as we do this, I do want to ask Krista from Cigna Healthspring to provide some of her commentary on what these results mean for her and also for Cigna Healthspring. So let's dig into some of these survey responses. So we have several questions here. First set of questions are, how many times have you been audited by a regulator? We weren't specific on whether it was CMS or state, but assume for a lot of these it's going to be CMS. And then how often does your health plan now perform its own audits on provider directories, so self-audit? So on the audit side, from the regulator standpoint, we see here that 50% of health plans have been audited at least once by regulators. Nearly 40% of them have been audited multiple times already. We can see that that's a pretty good motivator, pretty good catalyst for health plans. Once these results get up to the C-suite, start investing their own resources into measuring their accuracy on an ongoing basis. And it's one thing that we've been encouraging all the health plans that we've been talking to. You've got to measure your own accuracy, whether you use our solution or not. I want to make sure that data you're bringing in is good data that is going to be reliable. So many have spun up their own call centers, done statistically significant sample analysis, per the NCQA requirements of some of our state regs that we're seeing. So 88% of plans auditing their directory information at all. 67% are doing it multiple times a year. So Krista, I'd love to get your input here. Are you seeing some of the same results here in terms of kind of the frequency of the audits and also the increased frequency that you're doing internally as well?
Yep, we kind of fall right in the middle. So we've had MA and MMP both audited, and really if they pick a small sample within the contract, and you get a huge spreadsheet with the data that they got from your directory. So they're actually going into our online directories and pulling the providers from there. And so you'll get that big file back, which has, they call the provider, what deficiencies they found, and then gives you a chance to concur or non-concur. And then you can go ahead and do your own research. So a couple issues there. Even if you received an attestation from the provider the day before saying that all their information is correct, it still is a deficiency if they answer differently when CMS called. So you can show rosters or whatever source you have, but they're looking at it from the beneficiary's point of view. So even if you have that kind of documentation, it's still going to be counted as a deficiency. So, and another problem that you get too is when you call the office, you may get one person one time, another person another time, and they may provide different answers to the question. Again, still counts as a deficiency. CMS, again, is looking at it from the viewpoint of the beneficiary. So we really have done monthly accuracy audits to be able to trend our data and see what's working for us and what isn't, and where we can change course and what we need to invest more in. But those audits that we do, we mimic CMS audits, and they're extremely important for you to track where you are. Everybody should be doing them, I would say, at least monthly.
Okay, thanks, Krista. I think we'll move to the next slide to just round out the survey results. So what we see here is, we ask the question, how has your plan's directory accuracy changed? So what we see here is that a small percentage, so 21% have been able to improve accuracy gains significantly, so over 20% or more. And then we've seen some kind of mixed results on smaller increases in accuracy or remaining the same. And then whopping 38% don't have enough information. So I think a lot of you guys are still collecting enough information to determine whether it's a trend or not. What's interesting to see here on the right-hand side is how health plans are employing different methods. And I know Krista is going to be talking to this a lot more about how Cigna Healthspring is doing it as well. but there seems to be a strong attraction to manual outreach, so phone outreach or mail or fax forms to request providers to update their information. As you can understand, that's the easiest way to get started, and you can get results. Let's go into some of the challenges about doing that around the manual outreach side. So, in the previous slide, we showed the strong preference, but manual outreach, the CAQH position, as we've been talking with both health plans and providers, can be costly. It's expensive to hire a bunch of people to make phone calls. It may not scale. You have to ask a question about what your response rates are. We've seen, in general, phone call campaigns getting response rates around the 30% range for location outreach. And then eventually providers may stop answering the phone call. So we see a lot of quotes here from providers who have expressed a frustration about phone calls and mailer campaigns. I've had a few examples of a provider receiving the same a phone call from the same plan twice in a day for the same specific piece of information. So they're up to their eyeballs in these requests. So let's move to the next slide. So we have to ask the question, well, if the phone calls and the mailer campaigns aren't going to be the scalable long-term solution, then how do we do it? Well, we've got to standardize the information we're asking for, rationalize the number of requests that we're making on behalf of the plan. We've got to simplify and make it super, super easy for providers to get us the right information. So let's go to some of the details around that. So at CAQH, we worked with a number of health plans to collaborate and develop a solution on top of the CAQH ProView platform. So I won't go into all the details here, but as you can see, its solution's been around for 15 years. Over 1 million providers are using it. Got a bunch of organizations are already consuming the data for other purposes. So it made sense to build on top of this platform to capture good directory information. So if you go to the next slide, we'll go into the details about how we're doing that. So as providers are coming into ProView to update, review, and attest to their information on the regular basis, they're already coming in here. We're providing them quarterly reminders to review this information for directory purposes. And then when they come into the system, they see a really concise snapshot of their directory information, review and update it as appropriate. Then we send the updated information as well as a compliance report of the outreach to the plan. So it's kind of the end-to-end life cycle at a high level. I'm going to go into the next slides to show some exciting new enhancements on top of that. So we are now bringing in health plan data and reconciling it and comparing it with the data that the provider has already reported and showing the provider's discrepancy. So, up to this date, health plans have often had to kind of undergo the burden of figuring out what the differences are and figuring out what information to update and what information not. Now we're including the provider in that dialogue and in that reconciliation. So providers can say, yeah, I do practice at this location, or no, I don't, and I may never have, and so you should probably suppress that in your directory. So some exciting new enhancements there. And then the next slide, I'll kind of round it out with, we're getting into more organization-specific responses. So as we're getting this better information on the locations, we're also making sure that this information is relevant to specific health plans. So we're asking, are you participating with this insurer at this location? And are you accepting new patients? So we're asking this on behalf of health plans to providers at all of their locations, just to make sure that we get the best information, the most relevant information for a health plan through this channel. So I wanted to kind of cut it off there in terms of the CAQH portion. I want to hand it over to Krista, who is going to go through Cigna Healthspring's journey into directory accuracy and what her experience has been as well. So Krista, without further ado, I want to hand it off to you.
Oh, thank you. Yeah, so for our current state processes right now, we are meeting the 4 main components with CMS's requirement. So we are conducting our quarterly outreach. We're using CAQH for about 50% of our network. And really, this is because 40% of our network is delegated. And the fact that CAQH only covers professional providers at this time. However, it is on their roadmap to include facilities and ancillaries at a future date and time to be determined. So they are working on that. The rest of the other 50%, again, 40% of our network is delegated. We require them to sign an attestation that they are outreaching and validating their provider data that they provide to us in their rosters and add change term files. And the remainder of the providers get direct mailings from us for outreach purposes. For updating the directories within 30 calendar days, we do have a dedicated team, we call it the provider data validation team, that live in each of our markets, and this is all they do. They are accepting and processing changes we get on a daily basis. And then we've also reduced our access points for self-reported provider changes. So using things like CAQH, we're creating a new online form for our providers to be able to submit changes. There's dedicated mailboxes, so if our NetOps teams get changes, they have to submit it through those PDV mailboxes. So really limiting those access points so we can capture all provider changes and get them in accurately. We're also doing daily updates to our online directory, which helps meet the timeliness standards. If we can get it in, the quicker we can get it in, the more up-to-date the information is and is better for our members. And then we're also, for print purposes, we are printing directories on a monthly basis so that we can meet CMS requirements. And I believe Texas now, they put out their new critical elements, and directories there for their Medicaid products need to be printed monthly as well. So we're already ahead of the game with that one, at least. For being able to address member inquiries and complaints on provider access, we have really strengthened and enhanced our policies to meet the new requirements, and those help to ensure, timely routing of grievances and CTMs to the right people so they can be handled, effectively and efficiently. And the last one on here is internal monitoring. I can't tell you how important internal monitoring is. It allows you to really see where you are, and trend your data over time to see what's working and what doesn't. So we did establish a team to be responsible for this monitoring outside of the PDV teams, to complete audits on all the processes. So they do a directory accuracy audit, which mimics the CMS audit. So we can really see where our accuracy levels are. And that team has also developed policies and procedures, as well as SOPs to support our PDV teams as well as their audit protocols. So there's really 3 categories of challenges that health plans face with improving directory accuracy. First, with provider outreach engagement, a lot of times our providers don't know why we're asking for this information. They don't know that there's new regulations out and that's why we need it. They don't understand how we're using their information as well. So you tend to have some compliance and responsiveness issues, and also due to multiple plans reaching out asking for data in different formats. Those multiple touches, that there tends to be provider abrasion as well. So that's definitely a big issue we've seen. The next category is data validation. So location verification, as Ron stated earlier, when you look at those results, the provider not at this location is a huge issue. A lot of times they may only cover for colleagues or retest a location, or the group may just, add all their locations within the group to that provider, and not just the one which the provider actually practices at. That's actually a very common issue that we see. The data accuracy issues with delegates, as I say, probably 40% of our network is delegated, and they actually have a 15% higher rate of error than our directly contracted providers. So we're looking at working with them to improve those numbers. And then also, there's really no one source of truth for all provider data for the health plans to go to. There's not one place we can go where we know this is our source of truth for all of our providers. And then the third category is the downstream workflow integration. The regulations are changing so quickly at state and federal levels, so many health plans need new tools and technology that are really flexible and dynamic to making these adjustments, and it really does require IT engagement and resources. Staffing can also be an issue. Personally, we're receiving 6,800 changes a month that need to be worked manually. It takes a lot of manpower to do those changes, so many organizations really need to staff up and, again, get that IT engagement to assist with items like, automation to take some of that administrative burden off. So going, deeper into each of these, these are some of the opportunities that we've seen around the challenges that we faced. So for provider outreach and engagement, non-responders really do need additional outreach attempts. We haven't received an attestation or a change, so we don't know if our data is truly valid. Are we actually reaching them? Are we getting to them to validate their information? We need to increase education efforts. Like I said before, they don't always know what we're requesting this for. They may think all the addresses we need are for, for claims purposes, so they're providing all the addresses in the group. So really education and awareness for providers to know why we're asking for this and why we really need updated, accurate information. And then, continuing to work with delegates and stress the importance of their provider directory accuracy. We are looking for those who aren't able to increase their accuracy to possibly convert their providers to CAQ outreach. And we're also looking at possibly automating their rosters that come in on a regular basis so that we can update our systems through automation. So for data validation, we're increasing our engagement from our NetOps and customer service departments, through NetOps office visits and customer service calls to validate provider data. The more touch points, the better. The more we can touch the provider and really validate what they're doing, the better it is. Also using, cleanup with data analytics. So for those claims audits, we really are looking at the past 6 months of claims to see who has not submitted a claim and doing research and outreach as necessary to those providers to make sure they're still par. Did they move? Are they not with that group anymore? Any number of possibilities so that we can take them out of our data. And actually, this has become a regulation in Maryland and Georgia at this point that these type of audits need to be completed. And it really is a best practice to do it across the board, however. So we are doing it across all of our markets. Hospital-based locations. If you're looking at providers who are hospital-based, a lot of times they're actually hospitalists who should not be in the directory or HSB tables. They can't take appointments. Provider members can't really choose that provider. They should not be included in either directories or HSBs for network adequacy. And the big one, looking at providers with more than 10 locations. We have, started looking, we're starting big, so looking with providers that have 10 or more. We have found this data is really usually inaccurate when you do targeted outreach and find that we can suppress a lot of the addresses they provided. And you can see the numbers, as practices with one location usually have like about 30% error rate. And it jumps drastically to almost 60% for providers with 2 locations. And then at 7 or more locations, the error rate is over 98%. So looking at these providers with these multiple locations is essential. Again, they'll list all the providers with the locations within the group. It's a really common thread we see when we do the targeted outreach for these providers with excessive service locations. And for us, we require providers to practice at least 16 hours a week to be listed in our directory and used for network adequacy. So if somebody is saying they're working at 5 different locations, we have a problem. Truthfully, they should only be able to have 2 or 3 locations that they can really manage the 16-hour a week that we require. And we do have some exceptions, in rural areas where there are providers that do have to travel to multiple offices, to provide their services. So for the opportunities for downstream workflow integration, thinking the HSD tables with directory data is important. CMS has made it clear that we need to match this data wherever possible. If we can't list them in the directory due to limited availability, or they're not truly practicing at that location, they should not be included in our network adequacy numbers. So syncing those systems up, and also doing, reconciliation with other systems and platforms. So, claims, credentialing, just really making sure all of our systems are on point, and have the same data. Using SharePoint manual workflows. So we found that that's been helpful to be able to make sure that every system gets updated with every change that we're receiving. And it really allows us to fully track the progress and the age of an add, change, or delete through the entire process. We are looking, actually we're not looking, we are going to be using a new onboarding tool, a new workflow that will allow for more automation and a smoother transition between departments for adds, changes, and turns. It's going to be like a one-stop shop for the life cycle of the provider from interest to termination, which actually really helps because it pushes the data to the correct places where it needs to go. If it's billing, it's only going to go to the claims system. If it's, they're like a hospital affiliation, it'll come to us, for directories. It just gets pushed in the right direction with that. So a consolidated database to be like our source of truth is what we're looking to create as well. Basically a provider data management tool that almost works like a hub and spoke system, where the hub is where all changes are made, which then feeds into all the systems that require updates, for claims, credentialing, directory, HSDs. And again, this allows for that consistent data across all systems. And additional automation is huge. We've automated several of our national vendors for adds, changes, and terms. It's really lessened the load on our PDB teams and allows for more accuracy as more errors occur during manual entry. We've automated over 50,000 changes in the past 6 months, which is huge. So those are manual changes that did not have to be made by our PDB teams. And we plan to automate the remaining national vendors this year. And like I said before about delegates, looking to do some automation there as well in 2018. Okay, so we have multiple tactics to try to reach our goal of improving our accuracy in our directory. Reducing the manual changes. Again, this really increases your accuracy rate because of, manual entry really does have a lot more room for error. And it lessens your administrative burden on the plan and also allows for, updating in a timely manner, in a more efficient manner. So, those changes are getting into the systems quicker. And one thing we're looking at too right now is one of our tactics. We are in the process of launching an online forum for our providers where they can go in and update their the provider directory data for us, which really allows for increased automation since we'll be receiving this responses back in electronic format and don't have to manually work changes received by paper one by one. So providers can just go online, make updates. They no longer have to scan an email, fax, or mail, which lessens their administrative burden as well. So that's always a great thing for us. And it allows us really to outreach and more easily and effectively by using something like that. So reconciliation. There are definitely fields that need to be primary source verified. We don't want to get those from the provider. The ones that we list in our directory, like specialty or board cert or even facility accreditations. These things should not be coming directly from the providers themselves, but really need to be primary source verified. So hooking into the credentialing system to be able to get those types of data elements is something we definitely need. Database consolidation, again, I talked about this before, we need that source of truth, so that we can have, we know everything's consistent in all systems, and we have that actual, we know this is the right source to look at. The database consolidation, I'm sorry, that's what I just said. For Directories 2.0 implementation, this will actually help us quite a bit. I know CAQH, when they looked at this for a certain health plan who had been audited, they saw a 20% increase in accuracy if they had been using the new features within Directories 2.0. So we believe this is really going to give us a big bump in our accuracy, since it captures the plan-specific responses to address and panel status. So it's really going to help with, provider not dislocation errors. And the new platform also allows for more efficient reporting. So we believe we'll be able to automate more of the provider changes that are coming through directly into our system. And then Quest Analytics we are using. They offer things like, NPI validation, so we can see those NPIs that are invalid or deactivated, address inspection, so just as CAQH is looking at providers with 10 or more locations, they assist with that as well. And then they also do address USPS standardization that we get fed back, just like CAQH, so that we can make sure we're, we're listing our address as the correct address. It's not, it's actually a valid address. And they're also looking at specialty inspection to determine if specialty matches the NPI registry. And then looking at multiple specialties, like too many, they have like 10 different specialties, or if they have specialties that don't really go together, like an OBGYN and a cardiology specialty, it doesn't really click so much. So really using data analytics to look at that. So since CMS released their the call letter in 2015, we have seen a 20% increase in our data accuracy, and we continue to see improvements every quarter. So, we're finding what works and pursuing that, and things that don't work, we're, dropping and trying to find new opportunities. And it's really reduced our manual entry errors. This increased automation we're using has really helped increase those accuracy numbers. And then we also have those quicker directory updates. By doing it daily for the online and monthly for print, making sure our members really have the most current and complete and accurate data that we have available at the time. So for lessons learned, capturing provider responses accurately is really essential for quality improvement within your directory data. So doing things like limiting the points of entry to ensure we're capturing all the changes, and using automation to reduce the manual error helps you to do these types of things. A single source for provider data, it really helps with provider compliance and responsiveness, as it reduces their administrative burden. It reduces abrasion, so not getting multiple requests from different plans. So being able to have that single source is what we're really looking to eventually get to. Measuring your quality data is really essential. That strong internal monitoring is really an essential piece of the whole process. It really allows you to see, what's improving and works well with and as well as your pain points, to see what you need to do additional work or dig in and make changes. It allows you to, the overall trending of your accuracy is important, to see how everything's improving. You need to really start small, start as soon as you can, and because they're definitely out there, they're auditing. You don't know when you're going to get hit next. And they don't tell us when the audits are going to start again most of the time. So you never know when it's going to start. So really starting now, and then start small. Like I was saying, with your internal monitoring, you can see what works and change course with what with what doesn't, without a huge impact to your resources or your provider population data. And then once you know what's really working, engage your IT department so that they can help build tools and technology around that and push that forward. And again, I know I've preached automation, but it's so important. Automation really is necessary. You're getting so many changes in. Until you start this process, I don't think any of us really realized how much was wrong within our provider data. So with the amount you're getting back, you know, it really is a crucial thing to work on. It really lessens that administrative burden, reduces errors by manual entry, and then again, it gives you, you know, quicker updates to your systems to meet the timeliness standards. So really, in summary, you know, you need to review your administrative properties, baseline your data through audits. Like I said, ours mimics CMS. We actually call, you know, and verify all the information to see what, you know, what we have correct, and if they are called by CMS, what the responses would be. You know, outline your opportunities to improve once you baseline your data and start trending. You know, you can see what you need to improve in your data collection, your review, your publishing, to be able to get greater accuracy gains. And you need to look at your current resources, your IT, your staffing, your technology and tools. A lot of times these need enhancements. Your technology and tools need enhancements to be able to take in all this data that we're getting. So that IT engagement is really crucial, and then often needing to staff up as well. And then, you know, ease into your data collection to see what works and what doesn't. You know, start with pilots and small samples to see if it's working, so that way you can change course without spending too much money and without too much damage to your provider population data. You need to really assess your technology and support structure. Like I said before, you know, really look at opportunities to streamline your processes, your technologies and tools. You know, assess if you can work within your current tools and technology, or if you actually need to you need to outsource it rather than do it in-house. So taking a good look at the entire picture of the organization and the tools and technology you have, and seeing what your best options are. And then focusing on opportunities to improve provider engagement. So it is an issue. CAQH has really good numbers. I believe about 80% of providers attest on a quarterly basis. When you're doing your own outreach, your numbers are not that high. The response rate is definitely lower. So, you know, really trying to streamline your process for provider engagement. Try to reduce the number of inquiries you make to your providers, because they do start to get tired of it. That's why we're moving to an online form, feeling that that'll be a much easier solution. You know, try to standardize your questions that are, you know, so that they're really easy for the providers to answer. And again, you want it to be as easy as possible for them to submit this information, which Ron mentioned earlier. And systems that, you know, automatically flag and display data discrepancies when you're using your data analytics. So you can do more targeted outreach, not general, where you might have somebody in NetOps actually pick up the phone and talk to the provider and say, we see this, we just need to check in. And maintaining that really flexible and dynamic database is really important. Changes, like I said, are coming fast and furious from every direction. You need to be able to be flexible and change, you know, be able to make changes whenever necessary within the tools and technology that you're using.
Thank you, Krista. That was terrific. And we are running a little bit long. We have received a number of questions, and we won't be able to get to all of them today. However, I want to remind you, please go ahead and type your question into the question box on the right-hand side of your screen. And if we're not able to answer your question today, we will get back to you by email and respond. So first of all, I want to ask Ron a question, or a question from someone to Ron. Providers groups want to list all of their locations when they send us information for directories because they're concerned about claims payments. How does DirectAssure address those challenges?
That's a really good question. It's something that we've seen a lot too as we've been doing interviews and discussions with these provider groups who are submitting information, that they have this, you know, concern or anxiety around claims payments denials. And if I don't list this location, or if I don't submit this location and represent that the provider's there, then a claim may be denied. Well, in our solution in the platform, we're asking more specific questions about how often a provider is practicing at a location, Are they simply reading tester labs or covering for colleagues? So it's helped quite a bit. We've been able to identify a lot of locations that shouldn't be published in directories. So those questions do a good job of helping alleviate the concerns on the provider side around this.
Thank you, Ron. Again, several people have asked the question. You will receive an email by the end of the day tomorrow that will have a link to both the recorded webinar and to the PowerPoint. So you will be able to review this again. A question for Krista. How did you overcome the quote-unquote silo mentality in health plans to get all of these departments working together on one solution?
Really, it's just about relationship building and making them see the importance in it. Because it is a compliance issue, you say compliance and it's kind of like a red flag, people tend to jump a little bit more. So really, we've had really good luck with our other departments in trying to do what we do. And our IT has been really engaged with us, currently. It took a little while for them to get engagement in it, but now they're going full force with us. I think they realize the importance of it. And since we're launching like the workflow tool and some new databases, they've really realized the importance of that. So just really, I've sent that regulation to I don't know how many people. They wanted to see the call letter. They wanted to see all of the information in the background to make sure that what I was asking for was necessary. And I would freely send that and just, frequent touch points to get them to assist.
Thank you. And Krista, I'm going to ask you two questions combined. We have a question from a provider group. It says, we're using Direct Assure, but we're still getting requests from plans for information. And also a question that says, are all of your providers that are in your network required to use CAQH, ProView, and Direct Assure?
So for the first question, I think a lot of plans still refining everything that we're doing here. This is new to us. We've never had to do this, so we're on a learning curve. So there will be times where you will get outreach from the plan as well as from Direct Assure, unfortunately. We're trying, at least within Cigna Healthspring, trying to prevent that as much as possible, doing multiple reconciliations to see who's with CAQH so we can, make sure we take you off the mailing list and that kind of thing. And then I just completely forgot the second question. Can you repeat it? Apologize.
That's quite all right. Do you require providers participating in your network to use CAQH ProView?
Yes, for the most part we do. We do have certain, states where they require providers to use a different CBO. So, places like Arkansas and some other states. So there we don't require them to do the Direct Assure, use the Direct Assure. However, we are pushing them to do it. So we do a lot of communication saying, hey, we can make your life easier if you go sign up here. You can submit everything, and multiple plans can receive it. There's no charge, all the good stuff that comes along with that. So, so for the most part, yes, except in those states that have their own CBO.
And even though we have a number of questions remaining, again, please submit any questions that you have. We will get back with you directly, but we must end today's webinar. Thank you very much for participating, and if you have additional questions, we have everyone's email address there. You can get more information by going onto the CAQH.org website. You can log in directly by going www.directassure.org, and it will have all the information available on our Direct Assure solution. Thank you so much for participating in today's webinar, and we hope you have a good day.